Host, Dr. Spencer Nadolsky, and we have a special guest today, Dr. Sasha Hakman. She's a reproductive endocrinologist, a very specialized type of physician who helps with fertility and helping women conceive and get pregnant and throughout their pregnancy. Today, we're going to be talking about PCOS and GLP-1s and fertility in general. So welcome.
Thank you.
Yeah, we've been friends for quite a while, just, social media buddies, the whole social media doctor
Yeah.
friends type of thing. And you've made a few moves recently. You've gone to different states and been practicing, but all in all, you've been enjoying the whole reproductive endocrinology thing.
Oh yeah, I love it. It's a lot of fun. It's got the complexity of the endocrine part, but then you also get to do procedures and surgeries and obviously help families grow.
Yeah, so maybe you can explain what reproductive endocrinology is a little bit. So normally when people think of endocrinology, so like my brother's an endocrinologist, and we have many endocrinologists on our team at Sequence, and a lot of it's like thyroid and type 2 diabetes, and you get some pituitary stuff. But like, what do you do though as a reproductive endocrinologist?
So what people don't realize is we are actually OBGYNs who do subspecialty training after we become gynecologists for another 3 years. This is where we really specialized in the endocrinology system specific to reproduction. So there's a lot of overlap in terms of thyroid and diabetes. Um, but obviously, the focus is the reproductive system, primarily women trying to conceive. But there's also other aspects of the field where we treat people who are born with disorders of gender, for instance, like women born without a uterus or vagina, and then all the way to pituitary issues, sometimes adrenal, but when it becomes more medical endocrine, that's where we actually will refer out to a general endocrinologist.
Yeah, that's pretty interesting. You guys, so people don't realize, so there's medicine. So that's what I did. I did family medicine and then further specialized into obesity and lipidology. But there's also internal medicine, which is just adults. So I do the gamut of everything pretty broad. But when you do OBGYN, there's medicine, but you also are a surgeon,
Mhm.
and people don't understand that.
Yeah,
Like, and so you guys are just as much of a surgeon as you are anything else too.
yeah. And that's the beauty of it. If you like medicine, but you also like to operate, this is kind of the best field to go into because you get a combination of it all. And there's people can kind of focus in different aspects of it. There are some who love the obstetric side of things and they
Hmm.
just really focus on doing a ton of deliveries versus others who quit OB and just do gynecology, even though you're trained in both. And then there are those of us who then subspecialize. There's different subspecialties aside from infertility, things like um, gyn-onc, which is your cancers of the pelvic area, or those who do like pelvic reconstruction, things like that.
Yeah, you're highly specialized. So we got an expert on here, folks, who are listening. So I have a feeling you do see a lot of PCOS, polycystic ovarian syndrome, because that affects fertility, and people who have
Totally.
PCOS or are trying to conceive are probably like, hey, can you help me, Dr. Hackman? Um, so can you explain what PCOS is?
Sure.
Uh,
Yeah, it is, this really complex, slightly confusing metabolic slash endocrine disorder where essentially women have a hard time ovulating, so it usually presents with really irregular periods. They may have elevated androgen levels, either high testosterone in their blood, or it may present with unwanted hair on the face or body, hair loss on the scalp, things like that. And then typically they just have a ton of follicles on their ovaries. There's different ways of clinically diagnosing it, but that's kind of the gist of it.
yeah. And so we see them a lot in sequence because they typically have struggles with losing weight, and they want to
Yeah.
lose weight, for obvious reasons. People always want to, improve the way they look, but for health purposes,
Hmm.
they oftentimes have things like insulin resistance and other metabolic abnormalities. Plus, they might want to conceive. And so losing the weight um,
Right.
can help all of that. So Could you just go over some of the diagnosis criteria? I know we've talked about this before, but there's the Rotterdam criteria, but then there's some more specific organizations that get a little bit more into some of the androgen components. Maybe you can explain that.
Sure, yeah, I would say that the Rotterdam criteria is the most frequently used diagnostic criteria, which basically says after you've ruled out other causes for your irregular periods or your symptoms in general, then you would need 2 out of 3 of the following, which is irregular periods or what we call oligo or anovulation, as well as elevated androgen levels, either your serum testosterone levels or you have signs of high androgens, like I mentioned, the hirsutism being one of the big ones. Acne, not so much because that's pretty common amongst really anybody. It's not really characteristic of PCOS. But then also on ultrasound, one of the findings is polycystic ovaries, which means that you have a ton of follicles that tend to be in the periphery of the ovary. When we do the ultrasound, you see that the tissue in the middle of the ovary is really, really dense. Those are your theca cells that are responsible for your androgens. So if you have 2 out of 3 of those, then per the Rotterdam criteria, you have PCOS. But then there's the NIH criteria, which requires you to have both elevated androgens and irregular periods. So you need to have those two. They don't really care about the ultrasound findings. And then there's the Androgen Excess Society, which is you have to have high androgens, hence the name of the society, and then either polycystic ovaries or ovulatory issues.
And you tend to you don't go by the Rotterdam necessarily. You like the other ones. Is that right?
Yeah,
When diagnosing.
yeah, it's a little bit tricky. I feel like sometimes with the Rotterdam criteria, especially the way that they define polycystic ovaries, you have more of a tendency to overdiagnose it sometimes.
Mm-hmm.
And the reality is that because they say that basically if you have more than 12 small follicles in each ovary, that counts. But if you look at almost anyone in their 20s, they're going to have that. So it's really
Yeah.
non-specific. I think the
Mm-hmm.
reason that and this was decided in Rotterdam, Netherlands, at a conference. It was an expert panel who decided this. And I think the reason for it was just that they felt at the time probably that we're underdiagnosing it, and this will help kind of identify more people who may have PCOS that were otherwise missed.
Yeah. So for those listening, I mean, I know there's a lot of people in our program that have a diagnosis of PCOS. I'm always careful because, like, sometimes it wasn't diagnosed properly, and I don't know how many times you see this, but you do want to be careful of things like adrenal tumors, and then also something, especially in obesity, where we see it's rare, but Cushing's disease or Cushing's syndrome. It's an excess of uh, cortisol in the body, which can present similarly.
Yeah.
Uh, Changes in your periods, a little bit of hirsutism, insulin resistance, and you do want to get that diagnosed properly because then you have to fix the underlying cause, which is the cortisol and all that. But anyway, so do you see some of these other things where they come in with PCOS, or at least they thought, and then it's like, oh wait, there's something else going on here?
Really rare. Um,
Okay, so it is rare.
it is rare. I feel like I can count on one hand how many times I've had a situation where it was something else. Um, and then there is something that really overlaps with PCOS aside from an adrenal tumor, an ovarian tumor, or something like Cushing's. There's something called Hair-An syndrome. And
Hmm.
it stands for hyperandrogenism and insulin resistance. And acanthosis nigricans, which is a feature of
Hmm.
insulin resistance. So it's more of an insulin issue than anything else, leading to high androgen levels. And so it honestly is very similar to PCOS, but just a really more aggressive form of it.
Yeah, that would be hard to differentiate. How would they differentiate those with androgen levels, or how would they?
Yeah, it's really just based on the clinical and lab values, and because sometimes these women will actually have totally regular periods. They won't even have necessarily fertility issues. They just have crazy high androgens and insulin resistance on lab testing.
Got it. So yeah, a lot of people with PCOS always talk about they struggle with their weight, and there's a lot of gurus out there saying it's the hormones, and the hormones do contribute. A lot of what, when you look at a lot of these studies, some people thought that maybe the basal metabolic rates were a little bit lower in those with PCOS, and maybe that's contributing. There's a higher rates of binge eating. So I actually think a lot of it has to do with the appetite centers. So insulin resistance and these androgen changes and whatever else is going on can really dysregulate the appetite centers, which is why these GLP-1s work so well in those who have been struggling with PCOS, because nothing else, no diet or exercise stuff was really helpful. So whereas these GLP-1s kind of hit some of these receptors in the brain that I think become dysregulated in PCOS. So I guess like for you, when you see someone with PCOS struggling with their weight, do you take care of them yourself, or do you refer out to like someone like us or an obesity specialist or whatever?
So yeah, initially when I started practice, whenever you're starting in a new practice, you're a little bit less busy as you're kind of building. And so I had the time to really spend with some of my patients who are really serious about their weight loss. And then as you get busier, you just don't have the bandwidth to do that anymore. And then also what I noticed is that even teaching them how to count their macros, teaching them about resistance training, literally formulating specific workout regimens and plans based on their current fitness level, that still wasn't even enough as a specialist physician. And at this point, I started to realize I really need to just refer out to weight loss specialists, because those who are serious about losing their weight, I mean, it really does require an entire team to help with that. It's a very, very difficult process to go through and to also maintain it, because what I started to notice is that these patients would lose the weight, they would follow what I said, but then over time, they would just always bounce back. And it's almost not really sustainable to just spend the rest of your life measuring and weighing your food. As accurate and
Mm-hmm.
precise it is, it's a great way, but people just get emotionally fatigued from living their lives like that.
Oh, it's hard. It
Yeah,
is hard. Yeah. So, I mean, we talk about this all the time. So basically, we're kind of biologically driven depending on our environment. So uh, that's why these medicines are kind of biological tools to basically, so you don't have to weigh out every morsel that goes in your mouth. I
right.
mean, like some people do it and that's fine. I personally wouldn't be able to do that either. It's quite, it can be quite annoying. But again, for those who are able to do that, kudos to you. But you beyond PCOS, you also see other people struggling with their weight who want to improve their fertility,
Yes.
and you help in a kind way. You basically talk about, hey, weight loss could potentially help with your fertility.
Yes.
How do you have those conversations? It's got to be a tough thing because weight is obviously
Yes. And
difficult.
I try to stay really, really sensitive, because realistically, I'm small, I'm lean, and so
Mm-hmm.
I never want to come across as sounding judgmental, because that's the
Mm-hmm.
last thing you ever want to be. But I think just focusing on the fact that a lot of times being overweight, aside from lifestyle, it could also just, there's a huge genetic component to it, and like you said, the environment. So if you are surrounded by people who want to eat out every single day, there's the expectation, you get pressured to eat certain things, to have more drinks. Oh, I'm not really drinking tonight. Why not? What's wrong with you? Come on, have another drink. Try this. It's
Oh,
so good. And it's like
yeah.
your loved ones can actually be the ones that are totally preventing.
Some of the
Yeah,
worst.
they really,
Some of the
yeah,
worst.
absolutely. And so I always just say, like, listen, your weight isn't necessarily causing your infertility. We do know that with obesity there is well documented evidence of decreased egg quality, of
Mm-hmm.
endometrial issues for implantation. There's a higher likelihood of miscarriage. There's a higher likelihood of birth defects. And then even when you do get pregnant and you have a successful ongoing pregnancy, there's the risk of preeclampsia, gestational diabetes, gestational hypertension, a large fetus that could cause a shoulder dystocia and a delivery issue,
Mm.
C-section, post-op complications from a C-section like infection. So there's all these variables that we know very, very well associated with weight. So ideally, if you're able to lose that weight, then I can give you a referral to a weight loss specialist in order to help do that. And I've actually told many patients about your program to send them over virtually because I think that it's A, convenient, and then B, will actually be the thing to help them the most. But I mean, most patients have been really receptive. The biggest problem is once you hit a certain BMI cutoff, depending on the clinic you're seeking fertility treatments, a lot of times we are actually unable to do IVF due to the egg
Mm.
retrieval, and that's because there's
Mm.
anesthesia cutoffs. So
Oh,
yeah, so it's not
interesting.
even like it's not my decision. There have been many times where I almost kind of beg and say, please make an
Yeah.
exception for this patient. I'm the third doctor they've seen. They've always been put down about their weight. I understand the risk. She understands the risk and she's willing to accept the risk, but
Yeah.
she just doesn't want to delay fertility treatments any longer in order to lose weight, even though that is the recommendation. And a lot of times, anesthesiologists are like, no, I don't feel comfortable because, especially if they have obstructive sleep apnea or something and they
Yeah.
crump on the table, we're not at a hospital. They're,
Mm.
the ability to,
Yeah, it's an
it's,
outpatient
it's
treatment center. Yeah.
outpatient in an ambulatory surgical center. And so there's always that consideration. I know that certain practices where they do the procedures inside the hospital because they happen to have the embryology lab there, they're able to have way more lenient cutoffs or no cutoffs at all. I would say they're still pretty forgiving. Usually the BMI cutoff is 45, but you'd be surprised how often we deal with this.
Wow. Oh, that's interesting. Yeah, it sounds like you're able to have those kind of crucial conversations about weight without seeming judgmental or shaming. That's good. Um, there aren't too many people out there that are able to do it just yet. I think people are improving,
Yeah.
but so then okay, so you're seeing a lot of these GLP-1s probably coming in. We have these, not everybody listens or reads our lessons or listens to our videos, but like the prescriber information, the package label will basically say before conception, stop these drugs 2 months before, like even considering it. But then some people will come in, hey, you'll see them on social media. I'm pregnant. And like, hey, that person's on a GLP-1. They should stop. Are you seeing this as well? And do you counsel people on this?
So I haven't seen that mostly because I have a very biased population of people that just rarely ever conceive on their own.
Yeah.
It happens, but it's extremely rare that they come and say, "Oh my God, I got pregnant. I guess we're
Yeah.
canceling the treatment cycle now." And
Yeah.
so I haven't encountered it just because it's not a common occurrence for me. But that being said, I have the ability to kind of control things where, if someone has already paid for their IVF cycle, we actually tell them like, don't get pregnant, don't have unprotected sex for now. The main reason is like we really just want to get those eggs and make embryos before they get pregnant, especially if they're at a
Yeah.
certain age, because you now lose a year and change before you can kind of
Oh,
access those eggs, so to speak. So
wow.
it's actually ironically kind of a temporary period of time where we don't want them to get pregnant. So there's more control in the sense of, all right, you're on this GLP-1, you're going to stop it. And then, the next cycle, we're going to do your retrieval. And that's because we usually don't do an embryo transfer in the same cycle that we do the retrieval anymore. It's mostly frozen embryo transfers. And so there's definitely a lot more control, and they don't have to stop it as early on in the sense that we know they have to wait a few weeks to get to egg retrieval and then probably another month before they get to an embryo transfer. So by then it'll have been approximately 2 months.
Wow. Well, that's good. Yeah. So, I mean, we try to be as upfront as possible, making sure people know, hey, if you're on these medicines, understand the risk. Now, there aren't, we don't know in humans whether these things cause birth defects
Right.
or any issues. So it's not really studied well. We're just very careful about it.
Yeah.
And I know there was a statement by one of your gynecology or obstetrics organizations
Yeah,
that discussed
the
this.
American Society of Reproductive Medicine. They actually do categorize it as category X for
Hmm.
pregnancy, and that is because it's not. Maybe it's one GLP-1 in particular where there have been some animal studies showing birth defects in the animals. So obviously that's a concern, but the biggest caveat to that is whenever we do animal studies to look at drugs and their toxicity on the developing fetus, I mean, we're using animals like mice, which are way, way, way smaller than us, and they're using much higher doses than we would ever give to a human
Hmm.
being. So you take much higher doses than humans take in a tiny little mouse. I mean, it is definitely more likely to be toxic because there's got to be some sort of a threshold, but it's impossible to test in humans. We're not going to say, hey, let's do a clinical trial where half of you are going to get the medication during pregnancy and the other half doesn't, and then let's watch and see what happens. And then we have a whole generation of babies born with major birth defects.
Yeah, I think that wouldn't get past the ethics board, the
No,
IRB.
no, it wouldn't. No.
Yeah. Very good. Well, thanks for joining. I mean, anything else you want to talk about with weight loss and fertility and everything? You're the specialist. If there's anything we missed, but we kind of covered the basic type of stuff.
I guess I would just want to finish by saying, obviously, whenever you're trying to get pregnant, there's you're in a situation where you're trying to get pregnant yesterday, and waiting seems like a really daunting task. But if you have been advised to lose some of your body weight, if you have it in you, to find a program like Sequence um, to do that before the pregnancy, it will make the pregnancy so much healthier. You'll feel better. And then the postpartum journey as well. It doesn't necessarily always increase the chances of conceiving. It might shorten time to pregnancy once you've lost that weight. But I do think it's always like postponing pregnancy a little bit in order to lose some of your weight to get into a metabolically healthy place will really make the pregnancy so much better for you and for baby.
Very good. Thank you, Dr. Hackman. Uh, Hopefully, if you have anybody, friends or family, or anybody else who is thinking about conceiving and may be struggling with their weight and may be affecting their fertility, or they don't know, make sure you share this podcast with them. Thanks for
Yes,
joining
thank you for
us.
having me.